All right, ladies and gentlemen, I have the honor of introducing our speaker for today. He is a graduate of Kaunas Medical Academy in Lithuania with a residency training in Memorial Medical Center, Johnstown, Pennsylvania. He is board certified in family medicine and board certified in quality assurance and utilization review. As a physician advisor and director of utilization management for Providence, Sonoma County systems in Santa Rosa, California, he is a liaison between the case management department and medical staff. His many roles include second-level reviews, denials management and ALJ hearings, clinical documentation improvement projects, physician education and outreach, and various length of stays and cost of care reduction projects. He has been guest speaker for ACDIS, Optum Forum for the Physician Advisors Academy, the National Physician Advisor Conference, the National Association of Physician Advisors, and the Southeastern Physician Advisors Summit. Vice President of Operations of the American College of Physician Advisors, please help me welcome Dr. Alvin Gore.
Hi, everyone. I hope you can hear me and my video is working well. I'm surprised my picture still looks like me, which is a little strange, but I'm here not this. I'm sorry?
You haven't aged, Dr. Gore.
Thank you, I appreciate it, except my gray hair. So I'm here to talk to you about care coordination, so a comprehensive approach. Let me share my screen. Please tell me if you can see the slide.
Can you see the slides? Yes.
Thank you. I appreciate confirmation. So as Liz was kind enough to introduce me, I'm here to represent my organization, American College of Physician Advisors. And if I'm glancing a little bit off to the side, that's because I have two monitors and my slide is on the right side of me. Before I start, I just want to say a few words about our organization. Just like CMSA represents you and your specialty, your profession, the American College of Physician Advisors is essentially the only nonprofit professional organization that's, as you see on the screen, dedicated to development and advancement of the physician advisors. You could see the slide, you could read the mission, but in essence, we are there to promote the role of physician advisor in the modern healthcare environment. And the point I wanted to underscore is the membership is open to any interested professional. You don't have to be a physician to join our organization. And I understand the budgets are tight and membership dollars are scarce, but I wanted to make sure that you are at least aware of the opportunity. And I have our website listed. Feel free to go on the website, and there's a number of educational items and other tidbits, educational and otherwise, that are open to anybody, not just members. Granted, there is more information that's available for members. Oops, I'm sorry. But there is plenty of information that's available to non-members as well. So feel free to check out the website, tag us on LinkedIn, follow us on LinkedIn or on Twitter. All this information is listed there, and I hope you'll get the access to the slides so you could follow the information. What I wanted to point out, and this is my last promo slide, we have a number of learning opportunities on our website. We call it the Learning Center, and it's a series of educational modules, as you see on the screen, in a variety of topics. And obviously, your role is varied. You know, I've learned that when I talk to my colleagues or the case managers, care coordinators across various institutions, that the roles vary significantly. So feel free to check out the website and check out the Learning Center, because you'll find something relevant to you, be it case management, care coordination, UM, population health, CDI, and so forth. All of these are accredited and they're available for continuous education credit. We break them down into groups. As you see, there's a Learning Center A, B, and C, and the C would be coming out shortly in November. And we actually, because of the COVID, we had to cancel, just like you guys, we had to cancel our in-person meeting last year. So all 19 presentations are available for streaming They're a longer presentation, they're about an hour. And then I wanted to put a plug for our virtual meeting that will be taking place in October. If anybody is interested, feel free to register. We offer significant discount to case managers, and I think you'll find this information, the website and so forth, useful. Keep it in your bag of tricks and talk to your physician advisors in your facilities. As I said, these modules and all the information is available for both members and non-members. This is my commercial site. I'm done with it, and now I'm going to proceed to the presentation. So as you see, this is purely educational. I have to mention disclosures, and I have no conflict of interest of any sort to disclose or any financial conflict of interest. As my great teacher used to say, I have no interest in anything. But that's just a joke. So here's the learning objectives. I hope they're pretty simple and straightforward. At the end of this activity, you should be able to define the actual element of care coordination mosaic, define the functions of the elements and their interdependence, understand the impact of the participants, not just case managers or care coordinators, but how other participants of the patient care continuum impact the patient's progression. Understand rationale and how huddle become the centerpiece of a communication platform. And consider virtual options. You know, when I was writing this presentation initially, COVID was raging, and I thought, okay, this is very relevant. And then later on, COVID kind of started waning away, and I was thinking to myself, is this still relevant? And I have to say, unfortunately, it is. So we'll talk about it later on. Okay, so let's proceed. So just for information and curiosity, I wanted to tell you where I am. I'm pretty far from you. I'm on the West Coast. I'm in Northern California, and I'm in Northern California portion of Providence, St. Joseph Health System. You see the pointers, the pins on the screen. These are the 3 counties that we cover, and I'm in the red pin, so to speak, area in Sonoma County. So we have 2 hospitals that I cover in Sonoma County and other related facilities, but that's where we are geographically. And you probably heard about this area with wildfires and so forth, and unfortunately, that's the case. We're pretty close to the ocean, and yet we have lots of wildfires. Apples to apples comparison. I always wondered, why do speakers talk about their particular facility? And then I realized there's a relevance to that, because you could look at my presentation through a prism of your own facility and say, is it applicable to me? If you're working in the ivory tower institution like Liz does, for example, with lots of fellows, lots of residents, then you might have to look at it a little bit differently than if you're working in the critical access hospital. I work, as you see, in the community-based non-teaching institution. This is one of my hospitals that I cover. As you see, it has 300 some licensed beds, but I always ask people, what's your daily census? Because licensed beds don't really carry, useful information. So our daily census, as you see, it's 220, 230. We've been higher than that recently because of everything that's happening in the healthcare, but that's the typical daily census. So it's kind of an average community-based hospital. And the reason I'm saying that is because you could take the suggestion that I'm going to make and probably scale them up or down for your particular institution. This is a level 2 trauma center. And what's important, and this will be important later, our medical staff has a hybrid mix. In other words, we have physicians who are employed by the organization, and we have a smaller but still very active independent portion of the medical staff. And when I talk to my colleagues and when I talk to physicians, I sort of have to speak 2 different languages, because I think I have to approach these physicians from different settings slightly differently, and it's important. Okay, so let's start with basic. Let's start with definition. So case management and utilization management. So what's the fuss? So I tried to come up with a compare and contrast. I like slides that make things, they compare things side by side. And as you see, CMSA actually has a definition of case management. I'm not going to read it, but as you see, the keyword here is a collaborative process. And then you see the steps: it's assessment, planning, facilitation, care coordination, evaluation, and advocacy for the patient. This is actually directly from CMSA website. On the other hand, when I was looking what defines utilization management or utilization review, CMSA actually has no formal definition. So I had to use Institute of Medicine. It's pretty old definition. It could be updated for more recent time. But as you see here, as opposed to case management, this is a set of techniques to manage healthcare costs. So as you see in definition, it brings the finances into the kind of a more prominent position as opposed to case management. There's still case-by-case assessment and appropriateness of care. But as you see, the Institute of Medicine makes an emphasis on the financial aspect of the utilization management. And I think those of you who do utilization management or work with those who do utilization management would perfectly agree with that, where the reimbursement becomes one of the most important things in the process. However, despite the differences, case management and utilization management share a set of similarities. And obviously, they both are patient-centered, they both are collaborative, they both are time-sensitive. And this is the point I want to emphasize, and I keep emphasizing to our nurses as much as I emphasize to our care coordinators, the time is of importance, especially when you do the review or when you need to place the patient, because on the review end, time can close pretty quickly for inpatient changes or observation changes. And on the care coordination side, people have, especially elder patients, they have better days and worse days. And sometimes when patient has a good window, we need to be able to use the time and the opportunity provided and not to use this opportunity before the window closes. Obviously, both CM and affect the patient care progression, and they have financial impact, but in a completely different way. Case management affects the cost of care, and affects the reimbursement directly. And this is important to understand. A lot of institutions use, and I deal with it on a daily basis, lengths of stay as a proxy. And the reason we use lengths of stay is because it's very difficult at this time for many institutions to define actual cost of care. So we use lengths of stay as a proxy for cost of care, which is probably a much more relevant metric. So case management and care coordination affect that particular metric in a direct way by appropriate patient management and appropriate transition and disposition to post-acute environment. So look at the differences. As I said, I like slides that make things easier. One of my favorite principles when I was in the residency, kind of talking to the resident, is a KISS principle, keep it simple, silly. And I refer to myself in that. But I like things simple, so I'm not going to be using big words. But if you look at it, I hope you would agree. This sort of makes it simple. So for those of you who deal with case management primarily, you guide patients through a continuum of care. You do not have a direct impact on reimbursement, but you do impact the finances through a cost of care via lengths of stay. And that's what I was saying. It's very easy. Administrators love to measure lengths of stay because it's so easy to measure. You know when patient came in, you know when patient left. It's very simple. Now, I went here to our finance folks and I said, let's try to convert the lengths of stay into actual finance. Give me some ideas. And that's where sort of the rubber meets the road actually comes into being. And as it turned out, it's not that simple. So at the end of the day, what I was given was a simple average of basic bare bones cost of care for the patient on medical surgical floor, on telemetry floor, and in ICU, because obviously the costs increase as patients progress from med-surg to ICU. It's not perfect. I give you that, it's not perfect, but at least I have some sort of a financial benchmark to go off of just to estimate what the cost of care would be. What does it cost us to care for this patient? And I'm talking just very bare basic, cost of room, cost of nursing work, and basic what they call fixed expenses such as heating and building insurance, whatever makes that component. I'm not a finance person, but they gave me this combination, and I would urge you to start finding out what does it cost in your institution to care for a patient. How much does the day of care cost? And sometimes you'd be surprised. Everybody says, well, it costs X amount of dollars, but what goes into that? So be a little nosy and try to find out what's actual cost of care for the patient in your institution. To go on with case management, obviously, those of you who do it, you affect discharge planning and hopefully, and I always say, hopefully a seamless transition to post-acute care working with the families. And by doing appropriate discharge planning and care transition, without even realizing that, you work on the quality aspect of care for the patient. You work on population health because social determinants of health becoming more and more and more important. And a lot of what you hear on the news right now, the racial disparities and so forth, the racial aspect of medicine, actually are socioeconomic determinants, not necessarily racial. I'm not going to go into that tangent, but I'm just going to say that the social determinants of health are becoming very important. And I keep talking to the physician, and it becomes a mantra that, you know, we have to be holistic. We have to look at the not just the medical condition, but the social determinants of health. So I want the physicians to be speaking case management language. Because when I started in that field, and I remember going to my first meeting, coming home and say, I don't understand, you know, they're speaking a different language. But we have to kind of start teaching each other. And I'm completely humble. I've been taught by very good case manager nurses and staff, as well as the VM nurses. So we need to learn. We're not told, and we're not taught that in the medical school. So it, you know, don't be shy to pull your physician aside and say, hey, let me tell you something. Most of them will only appreciate it. And obviously, case management intervention are always real time. You cannot do it. You can plan for the future. You cannot do it looking back. On the other hand, as opposed to case management, when you look at the utilization management or utilization review, you see that a lot of work is focused on level of care status determination. So is this patient in ops? Is this patient admitted? What's the status? Obviously, as patient progresses through care, there are progression of care reviews. Now, they're very different than continuation of care work that's done by case management. This is a progression of care review to determine, does the patient still require hospital level of care? Are we looking into avoidable days? Is it truly going to be reimbursed and so forth? So as a result, and UR has a humongous, major impact on the reimbursement. I don't know what commercial vendor program, if any, you use, such as Interqual, MCG, or you have any internal based guidelines. But obviously, all of us utilize some sort of a guidelines for milestone in patient's progression. I think this is important, but I want to make a point that the main payer in this country is CMS. And CMS covers both Medicare and Medicaid. And CMS made it explicitly known they do not endorse nor they promote any commercially based vendor milestone progression as dogma. They defer to the clinician judgment. Even though we use these guidelines, they are just that, they are guidelines. We have to look at the patient as a whole. And then obviously a lot of work in UM and UR falls into audits and denial and appeal work for reimbursement protection. And this work could be real time, like doing a patient status review, or retrospective. And I'm involved in a lot of, denials, like RAG denials that we're dealing with right now, for example, that took place anywhere from last year to many years back. So I just wanted you to understand the difference between the case management and the utilization management, and not to confuse the two. Just like there's a difference, there are two models in case management department, and some of you might be working in one or the other. There is a hybrid department and there is a split separate role department. In the hybrid department, the duties are conflated. So there's a care coordination and UR duties. And you have to be very savvy with your time allocation, because you need to prioritize your time based on the immediate needs. You need to have basically good time management skills to balance and juggle, in addition to all the other balls in the air that you're juggling, to juggle these hybrid roles. And what's interesting, I think when people work in the hybrid role, they sort of have the benefit of learning both. And you have an enhanced case management function because you realize how much impact the UM has on the case management. You know what's going to be covered, what's not going to be covered. So you could adjust your work based on those, on that knowledge. On the other hand, if you work in a split department, you have a role dedicated staff. So you spend full time in that assigned role. So you become very proficient. So you have a dedicated time to either one or the other. But what that leads to is you might have a potential lack of comfort with the other role. So, our department went through both. And obviously, when people become very good at one, but have very little, if any, exposure to the other, they become very uncomfortable and not very savvy in handling the crossover duties. So case management frequently would rely on the UM for support in that area. So again, yeah, I'm not going to advocate one versus the other. It seems like most places in the country have a split, kind of a separate role departments. However, there are plenty of hybrid dual role departments at this time as well. Okay, so let me shift gears a bit and talk about patient's progression through the acute element of care. So how many phases are there? Now, this is traditional. This is history. This is not relevant right now. So you would say that, the care probably starts with somebody doing utilization review, assessing the admission worthiness or admission status, appropriate level of care, whether it's telemetry bed, med-surg bed, and otherwise, and then relaying this information to the case management, who in turn will start their patient progression management, and then relay this information to a physician for ongoing patient care. Now, I think that's how things used to be. If that's what you have in your institution right now, I would advocate maybe start looking into adapting it to a little bit more comprehensive approach. And that's the point that I want to make. So I'm going to shift from the traditional participant to more of an actual component of the care coordination. And as you see, I put this big red circle in the middle with case management, because I think you function as a linchpin, as a keystone. And I did my training in Pennsylvania, so keystone terminology is very prevalent in that part of the country. But you are a keystone, a linchpin of care coordination. And I have all these other circles, all the other components that feed into you. But I think you sort of become the grand central station, or the brain where everything gets processed and synthesized and actions are formulated. And the other components that I put there are the providers, be it physicians or mid-level practitioners, the UR nurses, CDI staff. I don't want to forget our CDI or CDS staff, because they actually are frequently siloed, but in my mind, they are indispensable part of this process. And somebody like me, and I wanted to put a plug. I don't know how many of you have physician advisors in your institutions, but people like me are sort of in a unique position, kind of we're sitting on a three-legged stool, working with care coordination staff, medical staff, and finance. And we have a kind of a broad scope of functions, so we can kind of understand the intricacies of each of the roles and be very important in connecting all the participants of the care progression. So I just want you to understand that there is more than just the traditional three-component progression. It's more like this. But in reality, when you look at it kind of through a comprehensive eye, it becomes more complex steps. So patient comes into the hospital environment, and I would assume most of you work in acute care hospitals. But if not, you still would understand that. When patient comes in, everything starts with initial UR review. And then this information should feed to the CDI, because what I recommend and what we use here, we have a CDI do the initial review and come up with the expected GMLOS, or in other words, expected goals for the length of stay for the patient. And granted that information may change, but at least it serves as initial guide for everybody on the unit to know how long do we expect the patient to be in house based on the initial information. That information in turn gets fed to the care coordinators. I don't know, maybe this is just local, but we no longer call our case managers. They're called care coordinators because then they don't just manage the care, they actually do more than management. It's more comprehensive. So the name that we've adopted is care coordinator. So the GMLOS and the CDI input gets passed on to the care coordinators who solicit the input from all the stakeholders. And this input is solicited via interdisciplinary rounds. And that helps them to coordinate care through the acute phase. So there is an appropriate outpatient transition either to outpatient case management, to post-acute facilities like one we just heard about it earlier prior to my presentation, to home or otherwise. So I think this is a more of a contemporary progression from the initial 3 steps, and we all need to be working together. There is no hierarchy. We all are colleagues in this process, and I think if anything, this defines medicine as a team sport. So for those of you who work in that might be a little repetitious. For those of you who are not, I just want to give a very high level basics overview on and Why do we care? Why do we need to know that? So I'm going to bring the why. When I talk to the physician, I always say, if I need to explain something and ask them to do, I always explain my why before I say what. So I always explain the rationale before asking why I would like them to do. So I want to compare and contrast, and I guess by now you probably noticed my style of slides. It's a lot of it is compare and contrast. I want to compare and contrast traditional Medicare and Medicaid versus commercial payers or Medicare Advantage plan. And the biggest thing I want you to understand is that the Medicare and Medicaid are regulatory payers. What I mean by that word, there is a Title 19 and Title 18 written in the Code of Federal Register. So there are regulations on paper that govern how Medicare and Medicaid function. As opposed to that, the commercial payers or Medicare Advantage plans, they are contractual payers. So your institution negotiates and signs a contract with the payer, and everything that this payer does, how it behaves, how it pays, and everything else is specified in the contract. So as opposed to the government putting out regulatory language that the Medicare has to abide by, the contractual payer have to abide by the contract, and contracts vary. And so your particular institution will function with a commercial payer or Medicare Advantage plan based on what contract was signed. And what I would like to encourage you, especially for those of you in the leadership position, is try to get involved in the contract negotiations or review, because a lot of the contract is out of the hands of the people like you who understand the reimbursement. And, sometimes institutions are in the rush and say, whoa, we signed contract with this payer, we got so many lives, to our institution, and they're going to pay us 125% of Medicare. Yeah, if they promise to pay 125% of Medicare, but they have 50% of denial rate, what good is that 125% would do? And the problem is contract people frequently don't understand the aspect of the the denial process, the appeal process. They just look at 125%, but they completely in the dark as far as what happens afterwards. So if that payer offers you 125% of Medicare rate, but denies every other claim, I don't think it's a good contract. So my plug to you is get yourself or your leaders involved in the contract process. It's laborious, it's tedious, but it's worthwhile. But getting back to the compare and contrast of Medicare and commercial payers. So as I said, for Medicare, the hospital participation in Medicare and Medicaid contract is governed by the condition of participation. This is again in Code of Federal Register, and that what governs your Utilization Management Committee. And it's very much prescribed by the federal regulation. On the commercial side or MA side, contract is everything. It governs pretty much everything that's there. On the Medicare side, you have to make sure, for example, that the level of care order matches the billing type. In other words, if patient has an observation order and your finance doesn't pay attention and submits an inpatient claim, that could be considered fraudulent because you have a mismatch between the physician or provider order and the billing time, or vice versa. You cannot cross bill if the billing type and the claim does not match the order. On the other hand, commercial payer frequently will say, yeah, we know patient was admitted. We see the inpatient order. We're going to deny the inpatient claim, but feel free to send an observation claim. There's no such thing. There's no such flexibility in the federal payer language or state payer. But on the commercial payer, there is. For example, as I said, frequently the commercial payer will offer observation payment for denied inpatient admission where we do not have to go back and change the order. It's not possible in Medicare, which has stipulates a condition code 44 process if inpatient order needs to be undone. And then last but important thing, when they do audits, Medicare and Medicaid, and I'm talking traditional Medicaid, fee-for-service, vast majority of the audits are retrospective because they rely on your institution's utilization management process, UR process, to establish the appropriate level of care. They pay you, and then they have a right to audit you retrospectively. Whichever number of auditors are there, I'm not going to go into that. On the commercial side, it's mostly concurrent. Usually today, you're communicating with the payer and telling them what happened yesterday. And they tell you yay or nay or otherwise. So the audits are usually real-time, concurrent, and there are fewer retrospective denials as compared to the traditional federal payers. Now, level of care determination. And this is primarily for Medicare because this is sort of the biggest payer in the country. So that's why I pay special deference to traditional Medicare. So people say, well, there are 3 levels of care, outpatient, observation, and inpatient. No, there are just 2 levels of care, and they're very simple. There's an inpatient care and outpatient care, and that's it. There is no intermediary. There is no purgatory. And even though that's what I call observation sometimes. But there are only 2 levels of care, inpatient and outpatient. So inpatient level of care in Medicare world, and you've heard it for years, it's a 2-midnight rule for fee-for-service Medicare. It's been on the books since 2014, so it's been there for many years. What the only point I want to make to you is some institutions, at least from talking to my colleagues, it seems like they remember 2 midnights, but they don't remember the second point. They don't remember that the 2-midnight rule has 2 components. It's 2-midnight rule, 2-midnight expectation of medically necessary services. So if your patient is just parked in the hospital for 2 midnights, but does not have an acuity to support this 2-midnight expectation, the time factor alone does not make an inpatient admission. I'm not going to go into details. I just want you to be aware that 2-midnight rule has 2 components, time and acuity, and you need to have both, or duration and necessity, as you see on the slide. There are exemptions to the 2-midnight rule. I'm not going to go into that, such as, unexpected transfer, unexpected death, and so forth. And there is inpatient-only procedure. I don't know if you've heard, earlier this year, Medicare put out a notice that they're planning on eliminating inpatient-only procedure list completely within the 3-year period. And that created a lot of angst in the provider community. So recently, Medicare published a OPPS, Outpatient Prospective Payment Schedule rule. It's just a proposal where they sort of walked back their initial proposal. That's the first time I saw Medicare kind of reverse inpatient to outpatient direction train. They walked back and they said, well, now we're thinking whether we will eliminate the inpatient rule altogether. We're probably going to do away with our initial idea. And moreover, we're actually going to add to the inpatient list almost 300 procedures that were initially eliminated. So be on the lookout. The final rule will come out in November, but that's actually quite a big change in Medicare's policy. So inpatient admission gets paid via IPPS, which is Inpatient Prospective Payment System, and they get paid based on the DRG. Each DRG has an associated what we call geometric mean lengths of stay, and the more complex condition, and that's where CDI colleagues come into play, is as we capture the patient appropriate acuity, the DRG or diagnosis related groupings. This is what hospital use to submit claims changes, and the more comprehensive the documentation, the more lengths of stay we buy, quote unquote, for our patient. That's why I keep harping on the point that CDI is an essential component of patient progression to the continuum, because CDI will allow you to have an extra length of stay if necessary, obviously, if there is a justification. On the other side, the outpatient level of care, there is a plain traditional outpatient. I'm kind of starting in the middle, and that's where many elective procedure fall in. For example, patient comes in for a scheduled revision of the shoulder non-union, or patient comes in for an ankle fusion. This is an elective procedure. Even though a patient might spend a night in the hospital, they still remain in extended, basically extended outpatient stay. I don't know about you, we have unfortunately a number of social admits, usually older patients that family brings and says, we can't take care of them anymore, they're yours. So these patients usually have no medical justification. So this is plain outpatient stay. Outpatient observation, that's the purgatory. That's the time where a physician needs to make a decision whether to admit or discharge the patient. So that's this transition. And this is actually a paid stay as opposed to an outpatient stay. But this is a decision-making time. It's usually 1 midnight. In various instances, Medicare says it could be up to 2 midnight. And these admissions, I'm sorry, not admission, these stays, because patient has never been admitted, so I apologize for my word. These stays get reimbursed through an outpatient prospective payment system. There is no DRG. There's something called APC, which is Ambulatory Payment Classification Schedule. And since they're not an official admission, there is no expected length of stay. So they get paid very differently. And I want you to be aware of it. For example, if you have a patient that has a total knee arthroplasty or total hip arthroplasty, these patients, based on the current condition, could be in either. So they could be either admitted or not. And based on that, the lengths of stay and the payment would be very different. And obviously, the inpatient admissions reimburse at the higher rate than outpatient stays, but it varies from area to area. In some places, the difference is minimal, in others is huge. Okay, I'm sorry, I think I spent too much time on that slide. Now, I just want to get back to the impact on case management planning. So when the reviews the patient, and again, the preliminary DRG would guide the lengths of stay. We have to be mindful of 3 midnights if patient needs a sniff, and that rule is on the book. Obviously, it's waived during the public health emergency, but I'm hoping and praying that eventually we'll get out of this mess. And 3 midnight rule might go back on the books. I'm hoping it won't, but obviously I don't have a crystal ball, but we need to be aware of it. And then the very important thing that needs to be communicated from the to the case managers is the 2 midnight lengths of stay expectation. In other words, if patient in outpatient observation or outpatient is there nearing 2 midnight, that communication has to occur to case management that observation patient is nearing its allowable time period. Do we need to keep the patient? Is it going to be turning into inpatient stay, or is it just a basic avoidable day that can be avoided? Now, for observation, again, is it 24 hours? Is it 48 hours? Do you monitor your 2 midnight stay? Is there a mechanism in your facility where the outpatient observation over 2 midnights is monitored? I don't know if you know, but observation patient payment actually covers only 8 hours. So there's an hourly billing that covers, that's submitted in 8 hourly unit, and Medicare pays only for 8 hours. So if your patient is in house for 48 hours, you're basically donating 40 hours and and getting payment for 8 hours. So the UM has to be very mindful, and keep in constant communication with case management, notifying them about this, because you need to be mindful of carve out time for procedures and tests and so forth. And they need to be on the lookout for a possible inpatient conversion. For example, somebody comes in with chest pain, is placed in observation, and then lo and behold, next morning, troponin skyrockets, and EKG changes develop. So patient has a bona fide MI and obviously has to be admitted, but that requires the communication. Somebody needs to keep an eye on it. The other thing, it's my pet peeve. For those of you who do UM, I constantly get UM referral for observation, and they say, well, patient does not meet inpatient criteria for admission, but they're here. My tip to you, and what I've been telling our staff, is when you review observation patient on the day following the initial presentation, don't look at the inpatient admission criteria. Look at the observation discharge criteria. See if the patient is appropriate for discharge rather than appropriate for admission, and then utilize that for decision to admit or not. So this is a little tip for you guys. And then when patients are outpatient, obviously you have to monitor them for discharge readiness, or conversely, for medical need to admit. And then please pay attention to social cases. People kind of shrug it off and say, well, this is a homeless patient. Believe it or not, homelessness, if it's documented, it's one of those HHC, hierarchical healthcare codes. So these are the codes that have importance in capturing for a lot of Medicare Advantage plans and so forth. So make sure your providers document that patient is homeless if they're homeless or something like that. So collaboration between UM and case management. Okay, what about CDI? I kind of teased it. Is it just the finance? No, it's not. So all CDI concept, and I don't know if any of you in the audience are doing CDI, it was purely financial. Well, let's capture those, what we call CCs and MCC, comorbid condition, a major comorbid condition. Let's put that query in the books to confirm the presence of those comorbid conditions, because they will change the DRG. It will take something from non-specific, plain vanilla heart failure to a heart failure with major comorbid condition, which will drastically change the reimbursement. And the problem was CDI and case management frequently were siloed and not communicating. And I'm trying to say that this is absolutely not the right approach. In reality, CDI and case management are very much interrelated. The way I refer to them, I call them two sides of the same coin, because you look at the patient, same patient from two perspectives, but you are interrelated. You cannot be separated. So, for example, when reviewing the record for medical necessity, both by the UM staff or by people like me, I frequently see need for CDI action. And if there is a mechanism for real-time communication or notifying the physicians or providers, that will impact the status. Let me give you a very basic example. For example, I look at the chart and I see that the sodium is 125, and physician document sodium 125, here's what I'm going to do, A, B, C, D. But sodium 125 is just a lab value. It's not a diagnosis. But the savvy UM nurse may realize that, hey, this is a condition that can make the observation patient eligible for admission if we have a diagnosis of hypernatremia on the chart. So just that simple, change by contacting a provider and say, you have this sodium 125 on the record. Can you name it? I mean, we have to be careful and then non-leading, but physician will say, oh, yeah, of course, it's hypernatremia patient. And then they will say, well, please capture it, please document it. And when you do that, please put in inpatient order. That's that simple, but that suddenly drastically changed the patient status. And obviously capturing the CC and MCC affects the length of stay. So if your CDI is savvy and talks to you, by capturing those conditions, they buy you extra time to manage your patient on the acute side. So CDI and UM and case management are completely interrelated. So we can go one step beyond that. There is what I call modern CDI. We go beyond the dollars. And the first step, as I just mentioned, it's the length of stay. And here's an example. And I'm sorry if I'm glancing to the right, as I said earlier. So traditionally, timely CDI is crucial to capture the length of stay. Here's an example for you. A heart failure patient with no comorbid conditions documented has an average GMLS of 2.4 days. So in other words, you can expect, or a patient is expected to be discharged in about 2.5 days. If patient has an elevated creatinine, I'm not going to go into details, and you're able to capture acute kidney injury, suddenly that becomes a comorbid condition. And if captured, that gives you a length of stay of 3.3 days. So just by capturing that elevated creatinine value, suddenly you have an extra day to be able to manage this patient in-house. And if patient happens to have elements of respiratory failure and it's documented along with the heart failure exacerbation, that's another day essentially for you to manage this patient. So be very mindful, because these conditions are icing on the cake. So they give you extra time to manage to get all this DME arranged or nursing home transition or what have you. But again, I keep harping on the same communication. And it could be done via shared platform, whatever EMR you use, or if you don't have that capability in EMR, there are other shared platforms like, TeleTracker and so forth and others. I'm not endorsing one or the other. What I am endorsing is the communication. And then here's goal number 2. For those of you who work with quality, what CDI captures is important on the quality side, because each patient has associated metrics, quality metrics, be it SOI or severity of illness or risk of mortality, as well as the present on admission condition, as well as mortality. Each hospital is reporting its mortality, and mortality is established by the documentation. I don't know if you know, a lot of metrics get reported as a ratio, as observed to expected. And I tell our physician and providers, sometimes we can't change the observed. It happened, patient died. What we can change is the expected risk for this patient by capturing the appropriate documentation. And just to give you an idea, I showed you the three conditions or 3 choices with the heart failure based on documentation. Those are essentially 3 different DRG for heart failure. In California, the state actuary or insurance commission expects the mortality for a patient with the lowest documentation or the CHF without comorbid condition to have a mortality expectation of 0.3%. So 3 out of 1,000. Now, on the other hand, if we capture the comorbid condition, that expectation becomes almost 12%. So this is 40-fold increase in expectation of mortality if conditions are captured. So if patient unfortunately dies, the expectation of this death have been significantly supported. Therefore, your ratio, your hospital reporting ratio is not affected. So I don't know if you have CDI specialists that work in quality. It's a fairly new concept. We have people working with that area for a number of years. But somebody like me or your colleagues my colleagues in your institution could be a key link between the case management and CDI. I think that's enough about CDI. Let me move to like they used to say, the rest of the story. And you've heard me say communication. It's the key, but keep it simple. So if anything you'll take from this presentation, please take the concept of multidisciplinary or interdisciplinary, whatever you want to call it, huddles. And I just want to make a point, because people say, why bother? And look at the screen. You see all this perceived inconveniences. Well, that takes time. It takes me away from my immediate duty. If the huddles happen to be centralized in a particular location, you might have to walk like to a different unit or a different floor. Sometimes you need to learn a different platform. Some people are hesitant talking to the provider, and things like that. There are reasons upon reasons upon reasons. And I understand that. I get it. This is might be new, might be a little uncomfortable. Maybe you've been doing that for years and to you it's a second nature. But I'm here to promote the concept of interdisciplinary huddle. And all these inconveniences could be easily disputed by the achievable benefits. And as you see, I put the very first item as, again, communication. Everybody's on the same page. And that there's so many benefits to that. And first and foremost, we all communicate in the same language. We all are on the same page. We establish working relationship with all the members of the treating team. And actually, it saves you time. You don't have to chase the providers. You don't have to do duplicative work. You don't have to call or page them. It breaks down the silos, and silos are terrible in healthcare. And it leads to a number of benefits, like reduction in lengths of stay, reduction in avoidable days, and so forth. And patient actually benefits in terms of progressing through a healthcare. So here are the critical questions: why, who, where, and when. And I don't have an answers for you, but I just have some tips for you here. Why is obvious, at least to me. Everybody's on the same page. We have improved throughput, lengths of stay reduction. We're able to decompress ED. We're able to take transfer if you take transfers, and so forth. So I think why to me is obvious. Who would be up to you to a degree. We have all of these that you see on the screen participating in our huddles, treating providers. We have representation from the hospitalist, from trauma service, from surgery, and so forth. You might want to have somebody like myself or my colleague in the institution, some sort of a physician champion or physician advisors. And it's very important to kind of lead the huddles or sometimes help with physician negotiation. Obviously, case managers, social workers. We have nursing representation, be it the lead nurse or the unit manager. And we have representation from PT, super important. Constant questions, constant need for PTOT. We actually have pharmacy representation, and sometimes administration makes an appearance. Where, again, it's intricacies of your own institution. Do you want to make them on the unit, centralized, in person, or virtual? This is for you to decide. And the time, again, timing should be related to the workflow, your workflow and the provider workflow. When do your physician round? When is the nursing availability? When is the protective time for medication for the nurses and so forth? So this is completely up to you. But those are the questions you have to answer prior to starting on or embarking on the huddle process. So we went through several iterations, and I just wanted to share with you our trials and tribulation because we made mistake. We tried to learn, and I'm here basically to share with you. So we started with physician leader who was overseeing the huddles. Usually it was hospitalist. We had administrator on duty. It could be, chief nursing officer, it could be chief medical officer, it could be somebody like myself and so forth, who is there to support the physician leader. And it assists in expeditious escalation. So in other words, for example, case manager can say, well, listen, I have trouble with this nursing home. They are giving me headache and runaround and so forth. And they say, okay, after the huddles, I'll call the DON. I'll talk to them and see what I can do. So we had both mixture of clinical people helping in their duty and non-clinical people. We even had somebody like director of finance or patient experience and so forth. And the goal was to assist in expeditious escalation. Treating providers were there, physicians and mid-level, unit lead nurse or charge nurse, whatever you want to call it, with or without manager, social worker, obviously from the unit, and pharmacy PT representation. So same people I've listed earlier. The point I wanted to make is these huddles were physician-led. And this is not the way I would recommend. It didn't quite work out. So from there, we switched from physician-led to case management-led huddle. And here's why. And again, same pattern of my slides that you've seen before. So we had physicians who were very differential to the attending. And if the attending would come to the huddle and say, hey, I think this patient will be in-house for another 1 week, they'd say, okay, because they were very differential. And it was based on the subjective assessment provided by the physician. So there was a variance from length of care that was based on the subjective physician assessment. And I have to give a lot of credit to physician gut feeling, but that's not the only guide we should have to go by. There was no validated target date for discharge. And inevitably, when physicians were leading it, the huddles would regress to clinical discussion, which may or may not be relevant to the care plan. So from there, we switched to case management-led huddle. So now it's the care coordinator or case managers that lead the huddle. Everything revolves around them. And the GMLS expectations that we get from our CDI colleagues are clearly stated. So the case manager starts the huddle saying, this patient's been in the house for 2 days, expectation is 4.2 days. So variation now is driven not by the gut feel, but by the objective factor. We have a validated target date that we're working towards. And we try to, we use MCG, but you might be using other criteria. And there is that we try to minimize clinical discussion. This should be care coordination, patient progression type of discussion, not clinical, only if it's relevant to the patient's care plan, we allow a clinical discussion. For example, does the patient truly need intravenous antibiotic? Can they be switched to oral? So discussions of that type are perfectly fine, but not getting into weeds of the clinical management. So it's like you've seen the Walgreens commercial at the intersection of happy and healthy. The huddle is the intersection of case management and VM management. That's where both processes cross. So again, I want to emphasize it's a case management led with physician champion support. And the two elements that are crucial, we need to be on the same page about the DRG, but more actually the GMLS expectation. And we need to hold physicians and other providers accountable. Without that, it's not going to work. And then if your EMR is able to provide preliminary DRG, feel free to do so. We try to have a certain percentage of cases re-reviewed on day 3 because patient's condition changes. And that's important to update, but at least start with a preliminary DRG, which would give you the initial target for the length of stay. But again, the two elements is the LOS awareness and physician accountability. And then just a few words about COVID environment. As I told you in the beginning, I thought would not be relevant. But when COVID hit, we had to adjust our process. We went through several iterations. We had sort of a conundrum of what do we do? How do we maintain the participant safety while maintaining the flow of information? So we tried to do all the simple stuff, limit number of people. We solicited recommendation from infection prevention. We tried to reconfigure the room. And then we decided to introduce a shared platform. And at that time, we used teletracker. You could use something else. But in the huddle, in the virtual format, we designated lead nurse for each unit as a person responsible for updating the information in the shared platform where everybody can go in and check. So we went through several, and eventually we came up with a virtual huddle. So obviously you need prerequisites. You need a shared platform. This institution uses Microsoft Teams, but you could use anything else. And then this platform obviously has to be adopted by all the participants. It's either through the PC or mobile phone, and everybody here has Teams installed on whatever device they use. And you obviously have to be flexible because you might need to log in on your phone if you're not able to attend in person and be able to participate. But at least technology provides this benefit. And my question is the virtual format here to stay? And I'm not sure, you know, like again, I'm hoping we'll get out of this mess sooner rather than later, but there are some benefits to the virtual huddles. It saves you time. It's in traveling, you can join offsite, you still can have a real-time interaction and discussion, and you can scale it up. You could have, you know, 5 people calling in or 15 people. I'm not advocating large group, but at least it gives you this opportunity. But as any technology, you know, sometimes you have technology issues, it doesn't work or something doesn't connect. We had to install additional signal transmitter for the wireless network in-house. And obviously there's an adoption delay. And the other word that I'm gonna say is, please leverage your secure texting if you have any. It's super important. Its ability to communicate the PHI in real time. But again, key to success is universal adoption. Similar to the multidisciplinary huddles, everybody, as you see listed on the screen here, has access to a texting platform, and it's super important. I used to call the physician, now I text them using the secure texting platform, and it's real-time communication. It's very helpful. So I'm a big technology proponent, and secure texting is definitely been adopted, you know, hands down, no question about it. I think I'm coming to the end of my time. I just wanted to mention few conclusions. Comprehensive approach is possible. Old model is not working. You need to bring everybody into the communication. Please make sure you have your CDI involved, establish the lengths of stay, you know, get yourself some extra lengths of stay by using the help from your CDI colleagues. And please look into adopting huddles, be it in person, be it virtual, because it improves coordination, removes the barrier, gives you the escalation platform, and use technology, use the virtual platforms and secure texting. Thank you very much. I appreciate your time.
Thank you so much, Dr. Gore. That was a great presentation. It ticked all the boxes for me because, for one, I am a case manager. I did and I'm currently a CDI nurse. So thank you so much. I am waiting for any questions from our attendees, if they have any feedback.
It was either too good or too boring.
It was really good for me. I don't know about the rest of the attendees. It ticked all of the boxes. It was enlightening to see how you molded every discipline, CM, and CDI. It was great. I've had experience too with the secure chat. I worked before for an institution that used secure texting, so that was an awesome tool for us, and I totally agree with you. I have Michelle Diamond saying excellent. Somebody wants to know where we can find a copy of this presentation. I believe that Maureen at the beginning of the session said that this is a recorded session, and if you want to access a copy of Dr. Gore's presentation, is that what Michelle is asking? I think this is I don't know, Maureen, do you have
Yes, I did. There was a link on the confirmation that was sent to you to download the handouts, but I can definitely send that out to everyone again.
And I forgot to say, this is my email. If you or any of you have any direct questions, feel free to contact me. I'll try my best to reply.
Jacqueline said, great job breaking it down for someone without experience in Thank you. Donna said, and I know this person, the entire presentation was excellent. Thank you, Dr. Gore.
Yeah, I always, when I went to lectures, if I pick up a tidbit or two, that was worthwhile to me. So I hope you guys picked up a tidbit or two.
I like that tidbit about the 8-hour observation pay. I didn't know that they'll only pay for 8 hours.
They do.